We can get started. Hi, everyone. Welcome to we call them infomars because frankly, I got sick of saying webinar during the pandemic. So we call these informational webinars infomars. Um, Before I introduce our presenter, I just thought I'd do a little housekeeping. Um, you are encouraged to ask questions throughout the infomar. I'll monitor the chat. I will also look for hands. If I miss you, just unmute and speak up. Also, I ask that you just stay on mute. I'll try to check to make sure that everyone's on mute, but I certainly don't want to mute you if you meant to be unmuted. Um, we are going to record this. If you have a question or a comment or something you don't want recorded, you can get in touch with Nicole, our presenter, or myself at a later time. I'm sure she'll take some time for you. Um, and we will post this and send you the link. It will be on our YouTube video, our YouTube channel. So welcome. And Nicole, can you come off? There you go. Thank you.
Hello.
All right. Before we start, I want to thank the Delta Dental Minnesota Foundation. I feel like I need to remind everyone and remind myself how much we appreciate them for supporting the Minnesota Oral Health Coalition. So I just want to give a shout out. They do a lot for us in Minnesota and the Upper Midwest. So thank you. All right. So the title of our Infomar today is Minnesota Healthcare Programs, Dental Benefits and Billing 101. This idea came to us from a group of people talking about the fact that they didn't know how dental was really paid for and how it worked. And I'll admit that I've been around long enough where I'm a little ashamed to ask too many questions. I have a lot of fear over that. I think people say, well, you should know that by now. And I say, yeah, I probably should, but I don't. And we know things change. And so when the idea came to me to host something like this, I went right to Nicole Ferrian because I thought, who is a who is a great use of or a great source of information. And as you all know, not everybody that knows things can communicate those things, and Nicole can do both really well. So let me introduce her. Nicole Ferrian earned a Bachelor's of Science degree in dental hygiene and a Master's of Science degree in community health from Minnesota State University, Mankato. She has over 17 years of experience in the dental and healthcare industries with expertise in project management, Medicaid, Medicare, and operations. Nicole serves as Appletree's Clinical Innovations Director, working to implement, oversee, and improve projects and processes throughout the organization. Appletree Dental is an innovative nonprofit dental organization with a mission to overcome barriers to oral health by delivering education, prevention, and restorative dental services to vulnerable populations and by providing leadership and innovation to transform the healthcare system. And Nicole, I think today you're working right into that sweet spot of your mission. So welcome.
Thank you. Thanks so much, Nancy. And I just want to ask this for everyone's sake too. I'll reference links throughout the presentation. On your website, are you going to post the recording and the PowerPoint slides too?
I would like to
Okay.
if that's okay
Yeah,
with
that's
you.
totally fine. And what I
Great.
did is I embedded links throughout the presentation that I think might be helpful for you all. And I'll reference those. And I took some snips that we'll go over. But I think that it would be helpful to have those links to refer back to. So that would be awesome if you don't mind posting that
No,
alongside the recording.
that's a great resource. Thank you very much.
Perfect. Yeah. All right. Should we go ahead and get started?
Let's
Okay.
do it.
I'm going to share my slides here and we will get started. Just one moment. And as Nancy mentioned, I am in presentation mode, so I can't see much. And so she will monitor the chat. And I am open to questions during the presentation or at the end, whatever works best for you. If there's a question that you don't want to forget or it's time sensitive or something, just go ahead and put it in the chat and then Nancy just call it out. I just wanted to call your attention to the fact that I can see my slides and my slides only. So Nancy will be the moderator in terms of questions. And I did include time for questions at the end too. So whatever works best. All right, I'm just getting this going here. All right, as Nancy mentioned, I am a maverick. And so I started just wanted to give you a little bit of background in terms of who I am and how I came to be here today with Nancy. I started as a private practice dental hygienist. And when I was in hygiene school at the end of my senior year, I decided that I wanted to do more than clinical practice. So I went back and got my master's degree and then made the merger into public health. So I started my public health dentistry career at the University of Minnesota School of Dentistry. I ran their UCare Mobile Dental Clinic, which is an outreach rotation for dental hygiene, dental therapy, and dental students at the U of M. I then worked actually directly for UCare. So I got out of the dental space and worked with UCare managing county relationships. So I would travel to counties, work through care coordination issues, et cetera. So I dabbled in dental, but I missed it a bit. And so I spent the vast majority of my career at Delta Dental of Minnesota. I started as a public programs administrator, essentially being an account manager for their Medicaid and Medicare lines of business, and then grew into a manager and then director. So I was there for over 6 years, and I have spent the last 4 at Apple Tree Dental. As Nancy mentioned, we're a nonprofit dental group. We have 8 locations in the state of Minnesota and 2 mobile programs as well. I just recently got a new title, so I have spent most of my time there as a clinical innovations director. I now have a title change to a performance excellence director. Essentially, I am responsible for project management throughout the organization, like working to make things effective and efficient. And I work on everything from clinical items to billing to operations, et cetera, which is how I'm here today because I don't know how, I didn't really picture this would be my spot when I went to dental hygiene school, but I've found my niche and know a lot about administration of dental benefits. So when Nancy came to me regarding this presentation, I did my best to put together something that was easy to understand, but then also gave you the detail you need. So as we go through the topics today, I'll say a little bit more. But I tried to come up with what would best meet the needs of the diverse population that's attending today. In terms of a little bit more about my professional background and some committees that I'm on that I have learned some of these details from, the Dental Services Advisory Committee is a committee that reports to the commissioner and makes recommendations. I've served on that since 2020 and am currently in a dental hygienist role. And then you'll learn a little bit more about critical access as the presentation goes on. But there is an organization called CAD Minnesota, and it's been around for a few years now. And it's a group of critical access clinics, Apple Tree being one of them. And I participate in our government affairs and industry affairs committees, which help to really advocate for critical access dental providers, dental benefits, work through payer issues, et cetera. So why we are here today. So here's what I came up with in terms of like presentation 101, what I felt would give you just enough information, but not too much in regards to like how do dental benefits and billing work for Minnesota healthcare programs. So I'll provide an overview of MHCP dental benefits and billing from a nonprofit dental provider perspective, essentially like what I do on the daily. And I touched on things in this presentation like regulators, payers, third-party administrators, the MHCP dental benefit set, prior authorizations, how to bill medical dental services, payment rates, and then charging for non-covered services. So what I'll do is I'll present these in module form. And then as I mentioned, left time for questions at the end. So I've been in this space for a while, as you've gathered, and I'm willing to answer questions around anything regarding these topics here or something different. So to start, let's talk about regulators. So in terms of Minnesota healthcare programs, Medicaid and Medicare in general are highly regulated. So Medicare is the program for adults 65 plus, And Medicaid is typically for those that meet a certain lower income level. So Medicaid can be Minnesota healthcare programs is how we refer to it in Minnesota, but there's Minnesota Care falls under that as well as Medicaid. So Centers for CMS or the Centers for Medicaid and Medicare, they're the federal regulator. Obviously, there's been a lot of federal changes this last year, but CMS is the regulator over DHS. So they provide overstate to DHS. So like there's a hierarchy of, well, let's call it bosses, and CMS is up here, and then it's DHS, and then it's the health plans. So CMS is responsible for DHS, who it's the Minnesota Department of Human Services here in Minnesota. They are what we would consider the state regulator. They are responsible for the administration of Medicaid in general. So, of course, today we're talking about dental, but that would also pertain to medical. There's, anything Medicaid, whether it's long-term care, facilities, dental, medical, durable medical equipment, et cetera. The state is in charge of that Medicaid program, the budget, et cetera. Of course, reporting to CMS and following their direction as well. And then the Minnesota Department of Human Services is the regulator for the payers. So I'll refer to health plans and payers throughout this presentation. A payer is just essentially an insurance company or like a Delta Dental or a DentaQuest, someone who's responsible for the administration and payment of claims. So Minnesota DHS contracts with health plans, and I'll get into the list of those as we go on here, but they're responsible for those contracts. And Minnesota works as an oversight with those health plans to make sure that they're following the rules and regulations, administering the benefit sets as they should, implementing corrective action plans when there's issues. And then, of course, the state and federal regulators are responsible for budgets. So moving on to who are the Minnesota healthcare programs, health plans. So in Minnesota, they contract with DHS, like I just mentioned. And as I talked with Nancy about in the beginning of this session, we'll put this PowerPoint on the MOHC page because I embedded a lot of links in here that you might find helpful if you want to do some additional work or investigation or research later on. But those contracts are public. And so I'll get to that at the end here. But as you can see, each one of the health plans, so they are for Minnesota, it includes Blue Plus, which is Blue Cross Blue Shield's Medicaid product. They call it Blue Plus instead of Blue Cross Blue Shield. DHS, so the Department of Human Services, they actually are their own administrator. They administer both medical and dental, but a very small population compared to the other bigger payers. Health Partners also does medical dental. Hennepin Health, Itasca Medical Care, they are a county-based purchaser. So for those of you that aren't familiar with what a county-based purchaser is, it's a group of counties in the state of Minnesota that they act as a payer. And they often have like tight-knit relationships with their providers and members in that area. And so Itasca Medical Care is up in the Grand Rapids area. Medica is a health plan. Prime West is another county-based purchaser. They are more down south, as well as South Country Health Alliance and UCare. So obviously there's been a lot of conversation about UCare. To my knowledge, right now, UCare is a subsidiary of Medica, but is still at this point a freestanding health plan. So those contract requirements that all of those health plans have with DHS, it's hundreds of pages long, which you could find if you go to the link. It's essentially what requirements do the health plans have from DHS. And it's like nitty gritty details here, like utilization review turnaround times, what benefits have to be offered, member communications, like can they text, can they call, like how soon do ID cards have to be sent. All of this is included in those contracts that the health plans have with DHS, and that's how DHS holds them accountable. Because if there's a breach of contract or the health plan isn't holding up their end of the bargain, then DHS would need to work with them on a corrective action plan. And as I mentioned, here's some examples here too about turnaround times, how our eligibility files are sent, etc. And then if you click on this link, I'll show you a snip in the next slide. But anyone, they're like fully public. There's a whole list of the contracts with the managed care organizations. So a managed care organization is typically, from my experience, known as like a health plan, but that's where, as you can see, they have them list the county-based purchasers listed too. So Itasca Medical Care, Prime West, South Country, they're all listed here. So if you were ever curious and you wanted to find out what contract requirements a certain health plan is responsible for, I mean, in theory, I have not looked at all of these. Like I said, they're probably, I'm just ballpark guessing from years ago looking, they're like 250 pages long. They should all be similar, but any and every contract requirement is included in these documents. So moving on to more on the dental side of the responsibility of the Minnesota Health Plan, health plans and payers. So current state as of today, they're responsible for administering both medical and dental services. Now, some of you may know this if you follow more dental, but in 2021, there was legislation in Minnesota that set a 55% utilization benchmark for health plans to meet. So, high level and a little bit of background, CMS, so that federal regulator, wasn't thrilled with Minnesota's dental utilization rate for Minnesota healthcare programs. They felt it was low. And coming from a dental payer perspective, it's 55% is pretty challenging to meet even on a commercial level, especially for adults and children. It'd be easier to hit for just children. But in Minnesota healthcare population, as most of you know, if you're working with these members, they have a lot of barriers, transportation, childcare, etc. And dental is often treated as a reactionary service and not preventative. So some patients are much better at going to their healthcare provider for preventative appointments, but dental only comes when there's pain. And so CMS, it was important to them to increase the dental utilization. Obviously, Minnesota felt it was important to increase the utilization. So there was this legislation set. Well, the health plans had a few years to work through this and to meet that utilization benchmark. And again, from everything that I've seen, heard, my knowledge in this space is that 55% is a real tough target to meet overall. And so that utilization benchmark was not met. So current legislation, it was backed up 2 years. This was originally 1/1/26. So now effective 1/1/28. So due to the health plans overall not meeting that 55% dental utilization rate, and I'll call out here when they talk about utilization, it was any CDT code. So it could have been a fluoride varnish, an exam, bite wings, any CDT code counted. But because that utilization rate was not met, a single administrator will now take over and administer dental. So that's right now, like I said, the date has been postponed to 1/1/28 through legislative process. But that is planned to occur on 1/1/28 with an RFP or an RFI. RFI is request for information, RFP, request for proposal process, went out through DHS after this, I'll call it trigger, was hit of, not meeting the 55%. And Delta Dental of Minnesota was chosen as the single administrator. So as of right now, there is work to move forward where Delta Dental of Minnesota will be the single administrator effective 1/1/28. That being said, as you can see the note in italics here, the county-based purchasers, IMCare, Prime West, SDHA, or South Country Health Alliance, they will continue the administration of dental services. But what that means for those other health plans, the Blue Plus, Medica, UCare, etc., they will no longer be responsible for dental services. They will only administer medical and their patients. So say, for example, if I had Blue Plus, I would have Blue Plus be responsible for administering my medical services. And then I would have Delta Dental be responsible for my dental instead of Blue Plus being responsible for both as it is current state. So I just put a few things here in case you wanted to learn more. This obviously talked about what they call the carve-out consequence. For the most part, health plans obviously like a medical dental integration, so they wanted to keep dental. But this was based on legislation that this occurred. I won't read the statutes in depth to you, but I just included some snips from the link that I just shared. This talks about that benchmark for dental access, where this was, like I said, put into legislation 2021, and then for coverage years 22 to 24, the commissioner established that 55% rate, and it was monitored with the health plans. And then if they didn't meet that certain rate, or there was requirements during that time, as you can see, then there was corrective action plans that were put in place to try to get them to meet that 55% target. And because that wasn't met, as you can see here, again, won't read you the full details, but just wanted you to see what the legislation looks like. Effective 1/1/28, it talks about how dental will be moved to the dental administrator, which again, Delta Dental of Minnesota was chosen through an RFP process. And then this highlights the responsibilities that that single administrator will be responsible for. And this is just continued for your reference later. So as I mentioned, current state health plans are responsible for administering those dental benefits, but many of them do hire what's called a TPA, or a third-party administrator, to do the dental work on their behalf. So the current TPAs in Minnesota for MHCP include Delta Dental of Minnesota. So Blue Plus, Hennepin Health, Medica, and South Country Health Alliance all contract with Delta Dental of Minnesota to administer their dental benefits. So while, for example, I'm going to use Blue Plus again, say I have Blue Plus Medicaid right now, Blue Plus is still responsible for my medical and dental, but they subcontract with Delta Dental of Minnesota. So if I go to the dentist, I'm still going to present my Blue Plus card, but it's actually Delta Dental of Minnesota that's processing my claims on the back end. But Blue Plus is ultimately still contractually responsible. And then DentaQuest right now is the current administrator for UCare. And this is just calling out that the Department of Human Services, Health Partners, Prime West, and IM Care all administer their own dental benefits. They do not contract with the TPA. Moving on into the dental benefits set. So effective 1/1/24, it changed, and adults and children had the same benefit set. Previous to 1/1/24, children had a more robust and comprehensive dental benefit set, meaning they had more offerings and more services covered than adults. That changed due to legislation 1/1/24. These are the links that I think you might want at some point if you work with members and you're curious as to what dental benefits are covered. And I have a few snips in the next few screens that I'll show you. But when we are checking to see if something is covered, we first reference this dental benefit provider page, which I'll show you in the next slide. And if it's not listed there, then we go to the fee schedule, which I will also show you how to look at that. The benefit of that dental benefits provider page is that it typically lists frequency and limitations as well. So for example, I'll see if I can pull this up. So this is the dental benefits page. This is a DHS page. You can click on it and say, I'm looking to check how often a prophy or like an adult cleaning is covered. I can click on preventative and it'll go and bring the CDT codes up, and it'll say how often it's covered, what the cadence is, like for example, like once every 120 days, I'm just making this up, and like a maximum of 2 times per year. So you can do that with any of these categories. That said, the stipulation is not all of the codes that are covered are listed here. So oftentimes a code will come to my attention and someone will say, hey, is this covered? And I check this page first and it's not listed there. But then you go to this page. So this is, I'm going to back up and just show you. This is the second link where it says MHCP fee schedule. This is the DHS's fee schedule page. So this is not just dental. This is CPT codes, like medical codes, CDT codes, dental codes. This is everything. And it's really confusing to read, which is why I wanted to just explain it a little bit to you. So again, we started the dental provider page. If it's not listed there, we come here. And what I look for, just like a quick overall cheat sheet, is I'll look here in the middle where it says PA indicator. So that indicates whether that procedure needs a prior authorization. A prior authorization is a procedure that's put in place where medical necessity first has to be determined. It's typically for higher level procedures like a surgical extraction or scaling and root planing or implants, like something that's a lot more expensive where the payer says, whoa, 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 like submit your x-rays, chart notes, etc. first, so that we can see that this is actually medically necessary before you render it and we pay for it. So that'll tell you that. As you can see, the effective date is also listed. And then the FAC code is what's really important. That tells you, is this a covered service or not? So that FAC code continued. I know this is lengthy, but I'll give you some examples. The ones that we see the most are 1, 3, and 4, which is in this right side. So 1 meaning general fee schedule. So that means to us, yes, it is covered. 3 means general price by report, meaning yes, it's covered, but it's not like a standard fee schedule. It's paid at a percentage of what you submit. And then if something's a FAC code 4, that means it's not covered. So I put an extra slide here so I could go through a few as examples for you. So if you look at the top, I'm sorry if this is small, but I can read it out loud. So the D0485, the very first one listed, it says the effective date that it was added to this fee schedule, and it shows a FAC code of 4. I stop there. That means it's not covered. There's really not much more to know. It's not a covered service for MHCP. So then the only way, it's not going to be covered by MHCP, that would be responsibility of a member. And at the end of this presentation, I have some information about how to bill and how non-covered services work. I'll do 2 more examples of different scenarios. The second from the bottom reads DO999. So, and then you can see under that PA indicator column, it has an A. That means that service requires prior auth. And you can see that there's a 3. So the 3 means that, yes, it is covered and it's paid as a percentage of charges submitted, but it does require authorization. So if you just render that service and submit something without a prior auth, it's going to deny for lack of prior auth. And then the most simple is this D1110. So that's an adult cleaning or an adult prophylaxis is what it's known as in the dental world. And as you can see, it's a FAC code 1. That just means pure and simple, it's covered, and there is a standard fee schedule rate. So moving in a little bit more to prior auth, since I mentioned that, the Minnesota Department of Services just determines what services require prior auths. And again, this is a handy link that you might use if you work with patients and you want to know what all services require prior auths. And I'll get to that in the next slide. I did take a snip, but as I mentioned, it's typically surgical extractions, orthodontics, implants, scaling and rip planing. Those are like the high expensive services, therefore they require it. And the overview page just talks about, that MHCP offers these comprehensive benefits, but there are codes that require prior auth. And then there's a lot of great links on their pages in terms of how to request a prior auth, what's included, etc. And as you can see, this is we hear this all the time, this last sentence: all services requested must be medically necessary and cost effective. I mean, there's been so much going on in the Medicaid space, especially in Minnesota, a lot of attention being brought to the Medicaid spend, that more so now than ever, we are feeling this in that there's a lot of stringent requirements in terms of medical necessity needing to be proven before anything is paid for, especially for a service that requires prior auth. So if you click on that link, here is what you'll find. Again, it's by service. So if you clicked on periodontics, that's where it would say scaling and rip planing. If you clicked on oral surgery, it would tell you surgical extractions. And then it would tell you, here's what you need. You need XYZ chart notes and x-rays, etc. And here's how you submit that prior auth. So the dental office is responsible for doing this. The member is not. But I just wanted to give you an overview of these are the barriers that we run into. And this is the extensive administrative work that needs to be done in order to just get services that are medically necessary covered. Another small hiccup when it comes to Minnesota healthcare programs is there's some services that are paid for on the medical side versus the dental side. So what that means is an alveoloplasty and gingivectomy are 2 primary ones. And I put a snip here just because most people don't know what that even is. But they're dental surgical procedures. It's not something that has to be done by an oral surgeon. It's within a general practitioner's scope as well, but it is on the oral surgery side. For whatever reason, Minnesota has decided that it's not covered on the dental side. It would be a lot easier if it was. But we have to submit them to medical. So those are CPT codes that are listed. And the office, like for us, Apple Tree, we are bigger. We have a billing team, but it's still a huge challenge because for these services, we can't just submit them to dental. They'll deny. We have to submit them to medical. And what's cumbersome about that is all of the health plans have different processes, procedures, requirements in order to get these services paid. And so just calling this out, and this is another administrative hoop in terms of it's not always cut and dry in terms of everything goes to dental. There are a few services like this that we actually have to submit to medical using CPT codes. Payment rate. So as most of you know, and this is what we usually get like the most questions about, and the biggest issue is that Minnesota DHS, they have to look at the budget, the Medicaid budget. They set the reimbursement rate. And I believe the last reimbursement rate increase went into effect 1/1/22. I don't think it's a secret, and most of you know this on the call, that the reimbursement rate for Minnesota healthcare programs is much less than a commercial or employer group rate. So for example, if I am on Blue Plus and I go to the dentist to get a cleaning versus my brother who is working for Cargill and is on a commercial plan goes to the dentist to get a cleaning for the very same service, the dentist is going to be paid far less for me versus him. So it creates a lot of access issues because providers feel like they're trying to run a business, they need to be paid fairly. And so they feel like, especially now with there's a big hygiene shortage, like a dental hygienist shortage, and they're getting paid a lot. And so providers are feeling like I can't even afford to see Minnesota healthcare program members sometimes because I'm paying more to see this patient than I'm even paying my hygienist in the first place. So it's a very large barrier, the payment rate, which is something that CAD Minnesota and others in the Medicaid dental space are constantly advocating for, is higher reimbursement rates to make it work. And health plans and payers, as a side note, may pay above the set rate to increase dental access. However, how it works is health plans receive what's called a capitation rate for each of their members. So again, using me as the example, if I'm on Blue Plus they'll say like, okay, Nicole Ferrian, here's her health status. We'll give you this much Blue Plus. And then Blue Plus has to decide, how much they're going to allocate to dental versus medical. And so it's not like the health plans, they have to be cognizant of their spend as well, especially with increasing costs these days. But they are able to say that. Like they don't have to pay the DHS set rate. They can pay above to increase dental access. Another issue currently is that general practitioners and specialists are paid at the same rate. This does not work from what we see in practice and my experience. Specialists go to more school, they make more money, their equipment is more expensive, often their staff is more expensive. So to pay a GP or a general practitioner and a specialist at the same rate just does not work. I don't think this happens on the medical side, but I'm not well enough versed to know. But I'm telling you that it does create a lot of access issues. It's hard for Minnesota healthcare program members to find pediatric dentists, oral surgeons, prosthodontics, because there's just not that many of them to start. And then again, their costs are even higher and they're getting paid that same rate. And so a lot of them just say, nope, like we can't do it, or they'll just do it on an exception basis. Thankfully, there is a critical access dental program. I mentioned CAD Minnesota. It's a policy group earlier of critical access dentists. So critical access dental is a program that gives qualified providers. So it's typically those who serve a significant portion of Minnesota healthcare programs an add-on payment. So CAD providers receive an additional 20% over the standard rate, which helps make the business of seeing Minnesota healthcare members or serving them a more viable business opportunity. So the goals of the program are to support dental practices with a high volume of active MHCP members and to create access, because the hope is that it's a reward, like you're seeing and serving these MHCP patients, we understand the reimbursement rate is lower. So if you get a CAD designation, you'll get a bump in payment. So there's a whole process for this, which is why I included the link here. But if you know of a dental provider in your area that you're wanting to see more MHCP patients, a lot of providers, I think from my experience, don't even know about it. So if they meet certain criteria in terms of seeing a certain number of patients, it depends, like where they're serving patients, et cetera. If they can qualify for CAD, it makes it much more sustainable to see MHCP members. Charging for non-covered services, I talked about this a little bit earlier in the presentation. This is a barrier for providers as well. So because of Medicaid rules, if you render a service that's non-covered, like a 4 on that fee schedule, but you don't have the patient sign this form at this link, this Minnesota Healthcare Programs non-covered services form, you cannot charge the member. You have to write it off. So that's really challenging for providers, because if you don't know the benefit set and you're not having the patient sign that non-covered service form and explain ahead of time that they're going to be responsible for this charge, you would have to write off a fair amount of charges, which obviously a provider doesn't like to do because it's not a sustainable business solution. So it's really important for providers that are seeing Minnesota healthcare programs to know the benefit set. That's why we use those links. And then be educated and talk to the patient about it. Like, hey, this is a non-covered service. I need you to fill out this form, which is very extensive. And it has to be done prior to the service being rendered. It can't be done after. Otherwise, what will happen is you run into a grievance and appeal situation where the patient will complain that they got a bill, and then the grievance and appeal team, whether it be Delta Dental or whomever the payer is, will say, okay, well, show us that completed non-covered services form. And if you don't have that signed, then you have to write it off. All right, Nancy, I'm going to stop sharing for a second, and so that we
Okay.
can move into conversation mode, but I'm just trying to get back to you here. Okay,
Yeah.
perfect. I
Thank
can see
you.
you. You're welcome.
I had a list of questions. I think you've got all of them. You answered all of them except for one, but I'd rather open it up to anyone in the infomar. Does anyone have any questions? Yeah, this is, like I said, you're just covering everything that I was going to ask about. And I love the links. I've got a list of links that I want to go back to. Any questions? Does anyone, or just comments? I, I'll just, I'll ask mine since no one is offering any questions. So with the CAD payment program, is that something that has to be like in your experience? And I don't want to put you on the spot, so you can always say no,
Yep.
but is is that a rigorous if I'm a clinic and I want to be part of that CAD payment program, is that a major deal? Is that for
I
me
don't
to
think so. I think it'd be worth the is I think the return on investment is there.
oh,
And so it's the Department of Human Services that is responsible for the administration of it. So how it works is this is there's you would go to that link, and then it talks about what the CAD program is and then the eligibility qualifications. Typically, it's a certain number of Minnesota healthcare programs members have to be served by your practice. And
okay.
so there is then this process where the CAD provider or the hopeful CAD provider works with DHS and has to submit. I'm not sure exactly what documentation they have to submit, but it's something just to demonstrate that a percentage of their practice truly is serving Minnesota healthcare program members. But then once they get that CAD distinction, then they go on a CAD list,
Mm,
and then that's how the payers know that they have to pay this clinic an additional percentage on top of what they're currently getting. So I mean 20%, if you that's a lot more. I mean, when you're
sure.
making a business decision, so it's definitely worth the effort, but it's entirely up to DHS. From what I've seen, I think DHS is really invested in continuing the program, and they
Mm,
understand the importance of it in order to continue to increase dental utilization. So that's why I called that out too, because I know a lot of you work
yeah.
in public health in different areas of the state. And from my experience, there's a lot of dentists that are willing to serve Minnesota healthcare patients on an ad hoc basis, like just because it's part of their community or it's someone's daughter or whomever. But if they're seeing a high enough portion, it might be worth it to just share that with them to say like, hey, it might be something you want to look into, because then also like from a public health perspective, it
Yeah.
could benefit you, because if now they're getting paid 20% more, they may be willing to see more of those patients or members that you're working with.
Yeah. Oh, that's a great explanation. Um, yeah. So we have a question in the chat,
Yep.
maybe off topic a little, but we are having issues getting secondary claims submitted through dental exchange to straight MA. It does not allow attachments for EOBs, etc. Are others having this issue?
Oh. So that's when it's straight MA as the secondary. Was it Trevor that asked that?
Yeah.
Okay. I only know
Yes.
enough to be dangerous, but I know we were actually just having this question yesterday about like e-attach services and things like that. And I think from what I've heard from our billing team is that I don't, and we actually asked Delta Dental this recently, is we're seeing more of this, like where we're being asked more often about like secondary and other insurance. So I don't know, Trevor, um, in terms of the answer to your question, in terms of like what you can submit, etc. But I am willing to ask our billing team, and then I can follow up with you. So I'll put
Awesome.
my email. Is it okay, Nancy, for my email in the
Yeah.
chat? And then Trevor, if you just email me, I will consult our billing team and then follow up with you.
Oh,
So I
that's
don't want
great.
to give you the wrong. I
Thank
never
you.
write my email address, so I'm having to check what it is. Usually I put it in the presentation, but I didn't. We have a billing SME who's really great, and so I dabble at like a high level billing, but I'm not actually like submitting claims and things like that. What I know is that, and I know others are facing this too, is we've been struggling from like a timeline perspective. Things are taking a long time. And also, like I mentioned, we are all of a sudden, I don't know if other clinics are seeing this too, but we're being asked constantly about other insurance, and like claims are getting denied for other insurance, even though then we call and like this patient hasn't had this other insurance in 6 years. So I don't know if it's related, but Trevor, go ahead and email me. I put my email in the chat and I will get you an answer from our billing team.
Thank you so much. All
Mhm.
right, we have another one. What about a dental provider that works as a contracted provider to provide hospital dental services for MA patients that require the use of general anesthesia for their dental services? The hospital bills the dental insurance, but I find that they write off a lot of charges, and my provider being able to get critical access payment, that would be nice for us.
Mhm. The hospital one is tricky. We too have providers that render, our special care team renders hospital services like at Gillette and some other places. And I don't know in that, like, because I think is the question, would they be able to get a critical access add on for the services rendered in the hospital so there isn't such a
And
big write off?
the way I'm reading it, but Melissa, you can either go off mute or you can, is that what you mean? And maybe you can't where you are.
I'll look too. I'll try to read it again.
Yeah. Keep in
Okay.
mind the hospital is a rural health hospital.
I don't know why I can't see that one. I
Oh,
can't see the question.
it's under, I think it was Melissa write to me or the person write to me, private message.
Oh,
Yeah.
I don't. So I think if the question, I'm trying to look at the chat too. If the question is, can you qualify for CAD rates if you're delivering the services in the hospital? That I guess I would say I don't know for sure. And you'd probably have to ask DHS that question, because I am thinking we have a sedation suite of our own, and then we do bill our own dental services. But I'm thinking that when we have our providers work at a hospital setting, you're right. I think the hospital is the one to do the billing. I don't think we are the one to do the billing. And I don't know if they're billing from the hospital. I don't know if they're billing dental or how that works. So to be honest, I'm not sure. That would be, you'd have to probably contact DHS, that CAD team, and ask them how that would work. And if they could get that add-on rate through the hospital, because typically CAD is by location. So I think what would happen is like the provider would have to be set up as CAD at that location.
And the person that typed that message, I can put you in touch with someone at DHS. So I'll do that afterwards. I have your email, so I can email you. Um,
And I think that CAD link too that I included in the presentation has maybe the DHS contact. I don't want to click out of it right now, but
yeah,
they would be the one to answer that question. But like the more I'm thinking about it, I think the provider would have to be set up at that as a CAD provider at that location. And so it would have to determine, like DHS would need to determine, could they be paid CAD rights at that hospital location or not.
yeah, and I'll also share a DHS contact for you to, because that's a great thing to look into, really useful. We had another question, or you have another question. Do you know or think with 2028 going to be a single dental administrator, might the reimbursement rates be increased?
This is a hot topic.
Yeah,
There's a working group called we call it DAWG, DAWG, and like Dental Access Working Group, I think is what it stands for.
it
So we've
does.
been that's through DHS, and so that question has been raised a lot, and rates have been discussed a lot. I would love if that were the case, but I don't think that there's going to be an increase. I think right now, from what I've gathered, Nancy, have you been attending those meetings?
I haven't been attending the dogs, such a
Yeah.
funny name. But I think I will from now on with my with
What I've
getting,
gotten from it, and I'm trying to also be careful because I just like
yeah.
here's what my take on it, what I've gotten so far is no, there won't be an increase. I think the people, the dental providers like Apple Tree, the U of M, et cetera, have been, Dr. Riggs is highly involved, have been trying to ensure that we do not see a decrease. Like
Yeah.
obviously an increase would be beautiful and so much needed, but I think there's worry that there could be a decrease actually with a single administrator because the health plans, like I mentioned early in the presentation, have the ability to pay add-ons, have the ability to negotiate rates, right? Like for example, if they need a provider down in Medelia, they have the power and the ability to say, hey, provider, we're going to pay you more so that you'll see our members. I think there's fear that that will go away when there's a single administrator. So I would say, from what I've gathered from those conversations, I don't think that there will be an increase. I think that's being advocated for. I think right now the effort is more like trying to defend our current rates. And the problem is like health plans are really good partners, so there's been, it's not only like there's dental rates and there's add-ons when they want to, and there's negotiating ability for specialty services, et cetera. And then health plans also have foundations that are often generous
Mm.
and so can have previously helped paid for capital projects and things like that. So while the legislation is set and like the gears are moving forward for the single administrator, there's definitely aspects to be cautious about.
That's a great answer. And um,
It's not black and white, that's for sure. But
yeah.
and so I would love to say yes, there will be an increase, but I think and then also like there has been advocacy for that with DHS as well. But given the current Medicaid state, it's not the easiest environment either to be advocating for increases, but we still are. I just think at this time, given the discussions that I've been present in, I don't anticipate there being an increase, unfortunately. I
Mm.
think we're doing our best to protect what we are currently being paid and then advocating for an increase. But I don't feel, I guess the word I'll use is I don't feel confident at this point that it's going to happen.
Thank you for that, for attending. Yeah, this was phenomenal. I wish I would have had this 10 years ago. But better late than never.
Of
So
course.
thanks,
Have a great
everybody.
afternoon. Thanks,
Yeah,
everyone.
you too.
Bye.
Bye, everybody.